It's a pleasure to be here. Thank you so much for the opportunity to come. I am an internal medicine physician that was invited to participate on the Institute of Medicine committee, so it's a pleasure to share with you some of these results. Why am I interested? Well, I was born the same year that benign myalgic encephalomyelitis entered the literature. I attended medical school during the HIV/AIDS epidemic in the US. I came back to Utah to do internal medicine residency the same time we started studying Epstein-Barr virus as a cause of post-viral fatigue, and also the same time the first case definition using the term chronic fatigue syndrome was published in 1988. And when I came home, I found my sister was ill with what eventually I diagnosed as ME/CFS. So my career parallels the illness of my sister. I was an internal medicine specialist until 1999. During that time, the Fukuda criteria were published. In 2000, I decided I wanted to learn more about this spectrum of illness, so I opened a clinic full-time for evaluation and management of patients with unexplained chronic fatigue, and then began to become involved in the field on the ICFS-ME board. Around the time the Canadian consensus criteria were published, I was on the CFS Association board. That's a national patient advocacy organization. Then I was on the CFS Advisory Committee, which is a group that tries to advise the government about needs in the community. And I actually was a small participant in the International Consensus Criteria publication. And then in 2014 was asked to come and provide a clinical perspective for the Institute of Medicine report, which paralleled an internal NIH evidence-based review called P2P, or Pathways to Prevention. So the Institute of Medicine is a private, nonprofit institution. It's not controlled by the federal government. Now it's part of the National Academies of Science, Engineering, and Medicine. It's a highly respected academic institution in the United States, and committee members volunteer their time to contribute to these reports. So the Institute of Medicine was offered a contract by the NIH, a combination of NIH agencies, to review the evidence base and propose clinical diagnostic criteria, because the Fukuda criteria are research criteria, not clinical criteria. And this was because the Chronic Fatigue Syndrome Advisory Committee had recommended that we stop using Fukuda criteria, start using the Canadian consensus criteria, and to eliminate the name chronic fatigue syndrome. So this was heavy pressure from the advocacy community, the patient community, and the clinicians in the field. And at the same time the Institute of Medicine contract was started, there was a long letter sent to the federal government saying to not do the project and adopt the Canadian criteria. So it started with a lot of controversy. The committee listened to hundreds of emails and letters from the patient population. Oh, and the committee was made up one half of people with clinical or scientific knowledge about ME/CFS, and one half expert members of the Institute of Medicine committee who brought they were luminaries in their fields to bring and guide the process. We included more than 10,000 peer-reviewed publications in the initial search. I listed the areas, the databases that were searched, and reviewed literature from 1950 until the middle of our project, approximately May 2014, and the report was released in February 2015. The title is here, and I would advise anyone who's interested to go online and review this excellent resource. There's a 2-page summary called Key Facts. There's a 20-page clinician guide, and the entire report is a great resource, and it's in sections that are easy to address by subject. The very first recommendation of this report was that physicians should diagnose ME/CFS if diagnostic criteria are met following an appropriate history, physical exam, and medical workup, and that there should be a new diagnostic code, an ICD-10 code. That has not been done. And the purpose of the report is specifically to improve clinical diagnosis. This is a tool for physicians in the community to recognize the illness, the core features based on the evidence, and the emphasis was on potentially objectively measurable features of illness. And our goal was a simplified initial approach to dramatically increase recognition and diagnosis if possible. So through most of my talk, I would like to quote directly from the report. So the pages are listed, and you can go to the report if you'd like to read any of these resources. But many, many Americans meet these criteria. They are largely undiagnosed, and it takes years to receive a diagnosis. This is a message we hear worldwide, of course. Physicians, again, are often skeptical, have misconceptions about the illness, and the medical school training is pretty much lacking in appropriate education for physicians. So much of the information is coming later. So these are the criteria. I will approach them individually during the course of my talk, but the report suggested that diagnosis be made based on these core criteria. And the core criteria are an impaired functional state characterized by fatigue with the emphasis on reduced functional capability, a post-exertional relapse or post-exertional malaise. It's not a very good term, malaise, but it came from the Fukuda criteria, I think, in order to carry that over. Unrefreshing sleep, and then either cognitive impairment or orthostatic intolerance or autonomic dysregulation. You can have one or the other or both. Those are core criteria, and they must all be present, and they must be present as a moderate, in a moderate to severe condition, and present at least 50% of the time over the course. And those numbers came from some studies by Leonard Jason that I will quote during the talk. Now, there are other common features of illness, of course. Pain syndromes, immune or inflammatory manifestations, neuroendocrine-like symptoms, and symptoms that might be associated with infection. But as you will see from the data we reviewed, they were not included in the core criteria. And physicians were encouraged to definitively make this diagnosis after 6 months of supportive care and diagnostic investigations. There were no specific exclusionary criteria, but it is expected that a differential diagnosis, appropriate workup of symptoms, treatment, support will be offered throughout the course of this 6 months using a provisional diagnosis. And the diagnosis can be made immediately if the symptoms are present and meet the criteria, but the differential diagnosis should continue until the diagnosis is clear. So I want to put the Canadian criteria up for comparison briefly because actually the criteria are very similar and parallel to the Canadian criteria. So the Canadian consensus criteria are in this list, and the IOM core criteria are in red, and the common symptoms are the additional symptoms in purple. So you can see it parallels the Canadian criteria quite closely. And the difference is the requirement for severity and frequency, which are lacking in the Canadian criteria. So this allows clinicians to include patients with persistent and more severe and debilitating illness. So the fatigue and functional impairment is a loss of function. And this fatigue of the illness reduces function and may be more severe than most other and many other chronic illnesses. And the report encourages physicians to investigate the impact of this illness on all types of functional activity, occupational, educational, social, personal. And one of the functional measures used in the report comes from a research tool called the SF36. It's a short form 36. That is the research tool, and the free online version of this tool is the RAND 36. Has a little bit of a complicated scoring mechanism. But this is a tool I use frequently and most researchers use. This is a tool, a validated, standardized tool across many, many chronic illnesses used throughout the world, actually, not just in the US. And there are 8 domains within the 36 questions: physical function, role physical, bodily pain, general health, vitality, social function, role emotional, mental health. You can see there's a spectrum of physical to emotional, with the ones in the middle being a bit of a crossover symptom. And, oh, almost fell off. So this is a graph from the literature showing SF36 scores across the 8 domains. Here's the physical end and the mental health end. And you can see that most chronic illnesses, have a bit of the scoring. You can see the typical scoring, and here are the normal population values across the SF36, with the most low score among normal being fatigue or vitality. So the vitality score I'm going to highlight and show you that in ME/CFS literature, the SF36 scores tend to be lower than all other chronic illnesses, and the low point is almost always the vitality score or the role physical, even and matching. So this is a small study I did in my clinic. These are the healthy controls, and here are the patients with ME/CFS participating in a study, and this is very consistent with SF36 scores across all the literature in ME/CFS. And this is a busy slide. You can find this in the Institute of Medicine report. All the references are here, too small to see. And these are multiple chronic illnesses: heart failure, hemodialysis, hepatitis C, major depression. And you can see, if you look at the one score, the vitality score, that as you go, this is the range in chronic fatigue syndrome studies of chronic fatigue syndrome, studies where patients had chronic fatigue syndrome and widespread pain or fibromyalgia, CFS, and multiple chemical sensitivity. And if the patients had met criteria for all 3 disorders, their vitality score was the lowest of all chronic illness scores. So we felt like this was a fairly good indication of the very low functional status and the high impact on quality of life and the ability to function in these patients. The second core criteria is post-exertional malaise or relapse after activity. And this is a worsening of illness under almost any type of stressor. So physical, cognitive, emotional, orthostatic stressors can all trigger relapse with this illness. There are many, many triggers reported across the literature. The duration of the effect can be days, weeks, months, and sometimes forever. So sometimes people do not recover from an event that triggers relapse or post-exertional malaise. This is a phenomenon rarely seen in healthy controls, but there are very few studies comparing this type of a report to other chronic illness situations. So really we need more research comparing this to other chronic illness. Throughout the report, we use tables from a study done by Dr. Leonard Jason in 2013. And he's one of the highly published authors in the field. In this study, he looked at 236 patients and 86 healthy controls in terms of their answers to a questionnaire it's a questionnaire he designed for this illness called the DePaul Symptom Questionnaire. He has a lot of publications concerning this DePaul Symptom Questionnaire. There are 54 symptoms evaluated. And we're going to use the graphs throughout the Institute of Medicine report to illustrate that if you include frequency and severity in the determination of patients, there's a distinct separation from healthy controls. And these were patients in a data bank from multiple clinics of patients who've been diagnosed with ME/CFS by a clinician, usually someone a specialist in the field. So this is the first figure, and you can see that the controls, this is the number of controls that answered this question in a positive fashion. And these are 5 questions approximating post-exertional malaise. And these are the percent of patients with chronic fatigue syndrome who answered the question that this symptom was present. Now, he has, in his paper, he shows the graphs if you don't include severity and frequency, and the lines are much closer. We need more studies to understand post-exertional malaise and what the physiology is and how to measure it, but more and more studies are trying to document the presence of this. And in the report, the objective studies used were serial day cardiopulmonary exercise testing. It's a reliable and reproducible test. Unfortunately, it's also a test that can cause a lot of post-exertional malaise in our patients. And I think I don't use this test in my clinic because it can really induce symptoms that sometimes can last a long time. I am involved in some research that was quoted in the report using gene expression following an exercise stressor. And I will deviate from the report for a moment to show you a little bit about that. So the cardiopulmonary testing is done usually on a bicycle. And this is the publication that came out just before the IOM report. Betsy Keller was actually on the IOM committee, and she was able to show these varied parameters in exercise, cardiopulmonary exercise testing. They were unable to reproduce the same work on day 2 in spite of equal effort in the cardiopulmonary exercise test. There have been several publications about exercise-induced gene expression changes, and these are the researchers that I work with, Dr. Alan Light and his team. And you may have seen this, one of them was published in the Journal of Internal Medicine, but these studies were able to measure, I keep trying down here, measure these gene expression or inflammatory markers before and after an exercise stressor. I will show you in the normal controls. So this level was the 0 level pre-baseline. We zeroed all those values to the line. The patients exercised for 25 minutes, just modest exercise on an exercise bike continuously. And then these gene expression markers were measured 4 times after the exercise. And this is the results in the patient group that was the initial study. And these were patients that I picked and sent to him because I knew clinically that they had post-exertional malaise. So you can see that these are fold increases in gene expression. I can tell you that there's a wide variability from patient to patient, but that most ill patient had the highest amount of gene expression in these studies. And you can imagine not very many patients will go volunteer for a study like this. So this reflects the less ill patients in my clinic. They also looked at gene expression after exercise in multiple sclerosis, and they also had a more high intensity exercise of the normal controls to see if they could reproduce this kind of physiologic response to exercise. So that was some time ago, and there have been a few papers, and there's been some, there's problems with gene expression in terms of the variability between assays and studies and between patients. But I did want to show you the gene expression and expanded gene expression of one patient. This is one of my patients. I know her very, very well. She is CX58. And after that initial study, they expanded each of the panels And this is, I'll show you just quickly, just look at it as a visual, okay? This is the summary of control subjects, and this is the result of one subject, same gene markers. Then the fatigue and pain gene panel was expanded in this one patient, and then they expanded the sympathetic gene panel in this one patient, expanded the mitochondrial gene panel, the HPA and stress gene panel, and the immune genes panel. So I'm not trying to say everyone has this kind of gene expression, but what I'm saying is if we can measure, try to find objective measures after a stimulus that creates the illness, we may have a better chance of picking up some of the physiology. So the third area, the third required, one of the core criteria is the report of unrefreshing or disturbed sleep. And this is a common theme among all of the previous case definitions, reported with one type of explanation or another. Almost all patients have some kind of difficulty with sleep, even if they only wake up completely unrestored from sleep, feeling as though the sleep was not beneficial. Now, in the review, we were able to show that primary sleep disorders are extremely common in this patient group. So obstructive sleep apnea, central sleep apnea, movement disorders, restless legs. But eventually, upon the review of the studies through the years, more studies were done excluding people with primary sleep disorders. Let me just show you, here is the report from the Jason study of these different questions asking about disturbed sleep patients compared to the healthy controls using moderate to severe and frequent criteria. And this, I just put this up here because this was a study that caught my attention during the review. This is a Dutch study. It's referenced in the report. 2013, they looked at a large number of patients after they'd been screened for primary sleep disorders. So those patients with primary sleep disorders were removed from the study. And there were 4 kind of groups of manifestations during complaints during the sleep study. And this is me in red trying to match my clinical impression. And I'm not sure there are 4 types of patients. They could be, the variability of people's sleep or the stage of illness or many different kinds of impact on their sleep. But you can see that there's a lot of disturbance of sleep. The 4th aspect is cognitive impairment or some kind of a neurocognitive manifestation, but with focus on cognition. And there were a lot of publications trying to look at cognition. It's really quite difficult to show objectively exactly what the problem is. And I think, again, we may need to do provocative tests where we make people more tired or more ill to do the measurements. But there were enough that a common theme of the cognitive testing came through as it slowed information processing on the cognitive tests. And there's some support for short-term memory and attention and concentration, but the theme that was most persistent. So the idea maybe is to direct new studies more toward the kind of fatigability that we see in patients with cognitive dysfunction. And it was most evident on time-dependent tests. So when people were rushed and having to do things too quickly, they had many more errors than if given time to do it at a slow pace. And the report says this may be responsible for much of the disability with this illness, rather than some of the other symptoms. Well, they're all bad, but this one is particularly bad because it makes it difficult to do any kind of work tasks, even if one is sedentary physically. And I put down here at the bottom, I think it's a reason that physicians become frustrated talking to patients because they're unaware maybe of their cognitive slowing and the need to have things written down and to help with reminders and memory reminders. It's not a reduction in IQ. This is a cognitive slowing that makes it more difficult for people to multitask, but rather need to do one thing at a time with attention and concentration. So these are the answers in the Jason study. That's pretty impressive, isn't it? The number of patients that reported these kind of symptoms consistent with cognitive compared to the healthy controls. The fifth, and remember, it's either cognitive impairment or orthostatic intolerance or both, and that's because some patients fell into one group or the other. And this was evident with the possibility of, the suggestion was both central signs and symptoms from cerebral underperfusion and peripheral signs and symptoms from underperfusion. And these studies were, there are a lot of studies actually showing changes, but maybe we need more. And they're definitely more prominent in the youthful population. So it's something that shouldn't be missed in adolescents in the pediatric group. I think this is one of the most underobserved aspects of illness because it can be tested in the clinic, in the exam room, if the physician will take the time to do it, and also to observe the patient when they're standing and in an orthostatic state. You can see the development of many signs and symptoms and reports while you're doing the orthostatic testing as it progresses. And tilt table testing, of course, is the gold standard, but it's sometimes difficult to access, and I don't think patients should have to wait to get into a specialist for tilt table testing. So there's a reference, this is included in the IOM report called the STAND test. There actually is a basis for this in the literature from NASA, the space literature, and I have a link to that on my website if anybody wants to download the instructions for doing the test. And this is an example, a bit of an extreme example from a real patient in my clinic, 31-year-old. The patient should lie down long enough for their vital signs to stabilize in the supine position, usually 10 minutes or more, and just a quiet room. Then check the blood pressure and pulse until you know that it's stable and consistent. So when you get approximately the same values on two measurements, you can complete the supine measurement. Then have the patient stand up and just lean against the wall with the shoulders touching, the shoulder blades touching the wall, not the whole body on the wall. This allows reduction of muscle compensation when doing the test, and have the patient relax and not chat, not talk during the test, although they should report symptoms that are familiar to them during the test. And in this case, this patient had a rather extreme response. You can see that the blood pressure drops significantly and her pulse escalates significantly along with recurrent symptoms, familiar symptoms to her of this underperfusion. So I would like to encourage primary care physicians to do this testing and understand if this is a component of illness, because this is objective and can be addressed in many ways. And it doesn't matter what the cause is. You can address it and reduce the impact of orthostatic intolerance if it's present. Each of the case definitions included descriptions of orthostatic intolerance except the Fukuda criteria. So this is not something new, and it's possible that orthostatic intolerance underlies many of the symptoms. And interestingly, when ICD-10 codes came out, the CFS code was no longer there. This is in the US ICD-9 codes. And there are no codes for ME, orthostatic intolerance, POTS, neurally mediated hypotension. They changed and took away the dysautonomia and replaced it with numerous codes. So we're a little bit at a dilemma about what kind of codes to use now. So we're using the post-viral fatigue code the most, the G93.3, as the same. I put this other slide up just to be provocative. There are many studies looking at the possibility of antibody involvement in post-infectious autoimmune process. This is the study that got my attention. This was published in the journal, The Heart of the American Heart Association, looking at autoantibodies in cases of post-infectious POTS and orthostatic intolerance. And I just borrowed one picture here. These are the known antibodies, and these are the patients that they looked at, looking at beta-2, beta-1, and alpha-1 receptor antibodies in this group. Now, this is very preliminary. There's more research coming out, but it was clinically resonant to me. This sounds very much like the pattern of some of the people I see clinically who meet criteria. So the additional symptoms, the other common symptoms that are included in the report, of variable pain, often severe, but not always consistent through the course of the illness and from patient to patient. Immune and inflammatory manifestations, neuroendocrine manifestations. I was part of the group that reviewed the neuroendocrine literature. It was very interesting, but it needs a lot more work. We spent a lot of time trying to show adrenal insufficiency, and the adrenal gland seems to work, which suggests to me that the signaling to the adrenal gland is probably the source of abnormality or some other central process. And even though we've looked for a single infectious cause for this illness, after 20, 30 years, so far we have not found a single infectious cause, but post-viral fatigue is associated with many different infectious sources, viruses, and some atypical bacteria. But the one that stood out the most in the literature was EBV, or Epstein-Barr virus. That's partly because that was the first question raised in the 1980s. I don't know if it's because the data are stronger. So the reason it wasn't a core criteria is that if you look at questions about pain across the group, you'll see quite a bit of variability. And remember, people can answer more than one question. But we would hate to exclude patients who didn't report pain. So that is why it's excluded from the core criteria. And the same with infectious and immune symptoms. It's possible that in many people, these aren't present all the time, or they resolve, or they only come back in relapse. So we wouldn't want to exclude people from the diagnosis if those are absent at the time that they are surveyed. So just to review, these are the core criteria. Pretty easy to remember. I try to think of them as 4, only number 4 is 4A and 4B. So then it becomes really easy to remember. Impaired function, presenting as a fatigue, lasting more than 6 months, but you can diagnose earlier. It should be a provisionary diagnosis until you've really exhausted a diagnostic and supportive workup. Post-exertional malaise, unrefreshing sleep, and 4A and 4B, cognitive impairment and orthostatic intolerance. In the chapter in the book, it says orthostatic intolerance or autonomic nervous system dysfunction as the title for the chapter. It didn't make it to the short form. And remember, these must be moderate to severe and persistent symptoms, not just something that happened in the past, because they're very nonspecific, right? Everybody's experienced a little bit of this sometime. But what's different is it doesn't go away. And then don't forget that there are other common features of illness that can be part of the syndrome presentation. So I'm going to end with a little bit of comment about the controversy following the report. The committee was asked to consider the name chronic fatigue syndrome and should it be continued. And it was clear, if you look at down here, the report said the term chronic fatigue syndrome should not be used. That's the recommendation. Because of the stigma and the misunderstanding associated with that term that came from the initial criteria. So the committee, which was a consensus committee, which means we all had to agree, we spent a long time talking and talking and talking about name issues. And I'll just say we got really tired. But, and I think in the report, more than 40 names were recommended by the public. And there's a list of all, I think, yeah, 40 or 50 different names. So even now, no one can tell, say what we should call this illness. And I think there's no problem with ME. It's just that in the US, it's been called something else. And also the term ME, I think, describes the most severe presentation of illness, and maybe needs to be a little broader for people who have the same illness process but don't become as severely impaired. That's my opinion. So the committee recommended a name that we thought might change the course of history, a name that would describe the illness based on the evidence base. So the name that was suggested was systemic exertion intolerance disease. And when the report came out, nobody noticed the content of the report. They all noticed the name. And actually, the federal government of the US has decided indirectly to maintain ME/CFS as the term. But I can tell you that some people in the academic community are starting to use the term SEID. So we probably created a little more confusion. But the other thing that's very important is the committee recommended that this be a temporary state, and that the base of research was very sparse, and there was so much more needed that another evidence-based review should be completed in no more than 5 years. So that was 2014 when we did, when the report was done. So I'm going to just conclude with, I've put some references here. I'm sorry, it's light, and maybe your cameras won't pick it up, but hopefully there'll be another way. You can put the problem is the name Institute of Medicine changed to the National Academy of Medicine. But if you put ME/CFS and IOM in a search engine, usually it will take you to some aspect of the report. This is the main page of the report, and you can choose among the short 2-page key facts, the clinician's guide, which I think is very, very good for clinicians, and then a free PDF copy of the entire report, which is really a great reference. I would recommend the summary to anybody who's interested because it gives a lot of background. I also put a reference to the NIH internal evidence-based review, the P2P. The Office on Women's Health in the NIH has a web page with some general information and help. And it's really interesting to track what the CFS Advisory Committee is doing because they're very aggressive and trying to make change. They tried to recommend a name and they couldn't decide either. So, but some of what's happening on this committee, very good also. Just for reference, I put up here a little bit more explanation and references to just some of the other case definitions and how they fit in. There's a long discussion of case definitions in the IOM report, if you want to go to that and read historically about case definitions. And then very last, I'll tell you that my clinic is now a nonprofit clinic, and our goal is to create a center of excellence. We do try to see patients and engage patients in clinical research. And if anybody wants to visit our website, you can go to batemanhorncenter.org. And then also over the years, we've posted many educational videos online. So if you go to YouTube, and then put Bateman Horne Center in. We have a YouTube site with many videos that might be helpful, especially for patients, and many for primary care as well. So thank you very much for the opportunity. And do you want to do questions, or should we wait till later?
No, thank you very much. I think. I think if someone wants to pose some question, you are welcome.
medical doctor. Perhaps you mentioned it in the beginning, but it has also been an exclusion diagnosis where you shouldn't be able to find any other reasons. But did you mention something about that, or what is your opinion about that?
Yes, I mentioned a little bit indirectly, but the report advises physicians to do a very thorough investigation for any other contributing causes. You know, the problem is, and I'm a clinician, is I've been using Fukuda criteria for a long time, they're research criteria. What do you do with a patient who has this illness and has other conditions that contribute to fatigue or pain or headaches or whatever? So I think it's important for a research case definition, excluding all other conditions that might confound research is important. When a clinician sees a patient, you have to be able to make a diagnosis based on everything that walks in the door, right? Whatever comes with that patient. And I wouldn't hesitate to make the diagnosis. I believe these criteria are quite specific for this illness, but that doesn't mean I won't address continually other causes of symptoms that contribute, if that makes sense.
Yes, a very good opinion. I agree completely. And thank you for a very nice and good performance. And what was very interesting and for me new was the genoma things after the stress tests. Do you know if you or anyone else are looking at the next step? I have learned that it's then called proteoma, genoma proteoma, and so on, because it could be very interesting to follow this.
Alan Light and Kathy Light had an NIH grant, a 3-year grant that this study was prior to the grant. And they have finished collecting data, and I think they've submitted or will be submitting their paper. And they used the same group of patients and came back and did a number of different assays and studies. So honestly, I haven't seen the results of their paper either. So I like the clinical correlation. I like to take the research data home and talk to my patient about it for them. But yes, I think you'll see something. So look for Dr. Light.
Thank you.
Yeah, down there.
Thank you for a very nice presentation. I'm Elisabeth Fernell. I'm a neuropediatrician. I have one question about age of onset for this disorder. And also, when you mentioned the executive problems, are there any indications of earlier executive problems in this patient group of regarding their school performance? If they have,
I think we need a lot more. We need more population-based research. But in my experience and in my collaboration with other clinicians, this is equally common. Well, I shouldn't say equally common, but common in children. It may be more common than other debilitating chronic illnesses. And maybe there is a publication that suggests it's the most common cause of school absence, prolonged school absence in children. There's a section in the IOM report that is only pediatrics and addresses all the criteria in one section, just the pediatric literature. So if you're interested in that, you should read the pediatrics section. And in my clinical experience, I'm not a pediatrician, but I know some. And the orthostatic intolerance is very common in the lower age group. And assessing cognition is very difficult in the younger kids get because they're not insightful. So you have to look at behavioral changes, all the things pediatricians do. It frustrates me. I like to talk to people. So no, I think it's important to do more.
Yeah.
I'm Claes Eriksson. I'm a specialist in occupational medicine. And as such, I meet many patients with exhaustion syndrome. I don't know if you recognize that diagnosis, as it's special for Sweden. But what's the main difference, do you think, with that diagnosis? Is it a prognosis, or how can I tell the difference?
I think that's why these criteria will be useful, because there are many, many causes of fatigue and exhaustion. I'm an internal medicine specialist. I've had a clinic for unexplained chronic fatigue for 15, 16 years. So I see all kinds of patients, patients with burnout, patients with mental health issues that are not picked up, fibromyalgia, widespread pain issues, and I think these criteria will help us to identify this group of patients that don't tolerate exercise as well, and maybe have more cognitive issues and more underlying physiology that doesn't respond simply to rest and rehabilitation. And it will help direct our research to understanding this better, because it's extremely debilitating. But that's not to mean that patients don't walk into the office with the whole spectrum of illness. That's the challenge for clinicians, is to be able to sort through what's going on with that individual patient. And I think sometimes this is not well understood by researchers, right, who get a patient with a well-defined illness to include in their research. So it's very challenging. And sometimes I'm not sure of the diagnosis for 6 to 12 months while I'm, talking to the patient, addressing their issues, doing more diagnostic studies and doing things, and pretty soon it's pretty clear that you have some core criteria that are not responding to the usual interventions. So until we have a biomarker, I think these are good criteria. I think if we adopt them in our clinics, it's going to help us.
Because there are very much similarities.
Well, then maybe we need to not be too married to our names of our syndromes, right? I feel that way. I think sometimes by wanting to give something a name, we miss some important information of overlapping conditions and the underlying physiology.
Thank you very much.
Thank you. One more question.
Okay. Hello, I'm Inger Ström, I'm a psychiatrist. I just wonder, your patients, if you discover that they are positive for example, for EPV or other infectional agents, do you treat them with antibiotics or antiviral medications?
I guess it depends what you mean by positive. So antibodies to viruses are an indication of prior exposure, and maybe other things, but they're very nonspecific, so I don't think you can make clinical decisions only based on antibodies. Sometimes I treat with antivirals if I can make a case for, the clinical presentation may lead me to do a trial of antivirals, but I don't use antivirals in all patients. And
no, but if they have, if they are positive for IgM antibodies.
Well, yeah, if they have IgM, then they theoretically should have early infection or subacute infection.
And what is the outcome? Do they get better in any way, or?
I don't think we have any data. So
okay.
I can't speak from the data.
Okay, thank you.